information on the physiological effects of a machine, of a ventilator body. But see, also the ventilator is extremely necessary in a lot of situations as well. Information on, and so I just want to kind of dispel some of the rumors or try to just clear it up. You know, I don't claim to know every single thing in the world. I'm learning as I watch, and I just want to give out my part from a professional standpoint.
Okay. What I would like for you to do first, and I'm gonna tell you why I want you to do this, because it's crazy. And it's crazy that it came from a brother whom I respect. I still respect him. And if he's watching, he know who I'm talking about. I'm not even going to call his name. But he said to me, he said, Saneter, I got a real doctor whose name is not Amin Ra, Amin Ray, Akusa, or something like that. So I guess he feels that you made up that name and you from the conscious community or you from the comedic world and that's not real. Explain to the people, brother, how you got the name Amin Ray. Amin Ra. Amin Ra.
All right. Well, my dad, who's deceased now, died when I was in 6th grade, was an Egyptologist in college, Knoxville College in Knoxville, Tennessee. Very astute in the conscious community, very astute with Black Power movement, stuff like that. You know, he'd always been deep into that. And so he named me Amin Ra from birth. Let me let you know, I'm not affiliated with Amin Ra Squad. I respect the brothers, but I'm not, I just learned about them as I watched Saneter's platform. So, you know, this is my name by birth.
There it is. You see what I'm saying?
It's my name.
There, even our own people could be like,
and I'm a professor of respiratory therapy at a college as well as work in the hospital.
Now, I hope that answered your question, my brother. You know who I'm talking about. I'm not gonna blow you up, all right? Because I got love for you. But now you see, man, we prejudice towards our own names and stuff. If we got these names, we think, oh, that's some add-on stuff, or we can't be born with these types of names. But you just cleared that up. So, my brother, what is so urgent? What is important? You hit me up early in the morning. You said, Sir, I got to come on here and talk to our people about what's going on with these ventilator machines and stuff like that. Let's get right into that, brother. You got the floor.
All right. Well, I just want to first say, no disrespect to nobody's thoughts or builds, but I do want to let you know that the ventilator is absolutely necessary in certain situations. We get to the point in our bodies where we're not able to generate enough negatory force to take a breath. Okay, that generates pressure. And so if we can't do that, we have to introduce positive pressure into the system. Okay. Now, I've been hearing a lot of people talk about, well, the ventilator, that's what's killing them. The ventilator is killing them. And I don't want somebody to need to be put on life support and decide not to do it because you've been hearing somebody saying the ventilator is going to kill you. All right. The place I work, we are a 98% weaning facility. That means when people can't get off the ventilator and they come to a long-term care facility like mine, we wean them at 98%. Okay, 98% of our patients come in with the tube down their throat and leave talking, okay, or die, one or the other. But to say that the ventilator is what's killing people, you have to kind of understand the intricacies and the processes on the body that the vent is doing, because it can kill you if you don't know what you're doing. Okay, if you don't know what you're doing, or it's not the right settings. Everybody has different settings. There's no one-all cure-all. Okay, when we put somebody on a ventilator, we have to give them a certain amount of breaths per minute, a certain amount of volume of air per minute, a certain amount of oxygen per minute. Okay, and all of that depends on the age of the person and how tall their lungs are. Okay, anatomically tall. All right, and so everybody is different. Now, if we go into it with the conventional, traditional settings on everybody, you can cause problems. You can cause. So I have some information for you, Si, that I can share my screen to show.
Yes, sir.
Effects of positive pressure on the body, okay?
Mm-hmm.
So let me share my screen. All right. And this is my first time using Zoom. I like Zoom. I teach with Microsoft Teams is what we use. And you can only see 4 people at a time. So I like how crisp this seems. Can you see it, Si?
Yes, we see it.
Okay. All right. So I teach again. I'm a professor at Concorde College in Introduction to Respiratory Therapeutics. Okay. When they come into our school, I teach the foundation of respiratory therapy and all of the anatomical parts about the heart and the anatomical position of the lungs. Okay. The mechanics of the lungs, the pharmacology that we introduce into the lungs. Can you hear me?
Yes, I hear you. Go ahead, brother.
Okay. All right. And so the reason why I say that is so positive pressure is what a ventilator does. Okay. When you cannot generate enough force, we have to introduce positive pressure into the body. Okay. Now, of course, this is some healthy lungs here. I always show this is some pair of pink healthy lungs. Of course, if you're smoking, you need to stop because your lungs are probably black. Okay. And so healthy lungs are generated with positive pressure and can have wonderful benefits. Okay. I'm not getting paid to push ventilators, to do none of that. My hours being cut. You see, I'm at home. My hours cut just like everybody else's. And I just want to get the information out there. Now, let me show you what hyperinflation of the lungs do. Okay. Now, this is just some preliminary stuff of my objectives that we will teach the students. Okay. I'm going to get into what we do. All right. So when we need to inflate the lungs, we either inflating the lungs because the patient can no longer inflate them, or they have been sedated, coming out of surgery, or have some kind of incision that's close to the diaphragm. Okay. Our diaphragm in our body is the number one muscle for ventilation. Okay. If your diaphragm is no longer working, you cannot breathe. All right. You cannot suck the air in. And so to say that no matter what happens, I'm not going to let them put me on a ventilator is silly. Okay. Because yes, I saw in the title, a ventilator, you can get addicted to the ventilator. The body can get adjusted to the machine doing all the work. All right. Just like the oxygen that we give is a drug. All right. People don't know that oxygen is a drug, and you can get used to it or addicted to it and be hard to get off of it. Okay. But it's at the same hand also necessary. So the reasons why we give positive pressure. Now, this right here is called inhalations of in-center spirometry, where you inflate your own lungs, right? You take a real slow, deep breath. So I'm sure you've seen this machine here by somebody's bed. This machine here. Everybody's probably seen one of these machines, okay? This is how you inflate your lungs if you have the strength, okay? With what's called an in-center spirometer. We set a volume that you should be able to get to, and then we let you practice it, try it, take slow, deep breaths in, hold it to keep your lungs open, okay? Because if you don't move or if you are sick, your lungs start to shut down little pockets, okay? That's called atelectasis, all right? All of my information comes out of Egan's Respiratory Therapeutics book. I'll show it to you at the end of this presentation. But as the lungs start to shut down, you start to build up what's called carbon dioxide, okay? When we live, and we metabolize, we burn oxygen and fat, right, and sugar. And that byproduct is carbon dioxide. And so our lungs get rid of the carbon dioxide with every time we exhale, all right? Now, for someone who is unable to get rid of the carbon dioxide, they go into what's called respiratory failure, all right? That is the point to where we have to introduce positive pressure, okay? we have to give positive pressure in order to ventilate you, okay? Because you have built up so much carbon dioxide that is about to kill you. Now, our patients that are on a ventilator, we maintain their pH and their CO2 and their oxygenation, okay? As they come around and get healthier, then we're able to give less support on the same machine and then finally pull them off the machine, okay? And they're breathing by themselves. That's called weaning you off the machine, okay? Now, let me show you what happens if you don't know what you're doing. And this is, I'm sorry, this is how I go through with all my students that I know you don't have that kind of time. So let me go to where I show you what's going on for positive pressure.
We got the time today, brother.
Okay. I didn't want
to get it all the way in.
All right. Now, when I'm evaluating a patient that's deep breathing, okay, because like I said, somebody who was about to go to surgery, like you said, I heard you earlier when I was cutting the grass, I was listening to one of your shows when you said you had got a colonoscopy. And when they put you to sleep, depending on how long the patient is going to be asleep, the respiratory therapist will come to you with that little machine, that little handheld machine, and say, hey, when you wake up, I need you to hit this machine a few times to pop them lungs back open, okay? Maybe not much on a colonoscopy because that's whatever they're doing is so far away from the diaphragm, okay? But somebody who goes in and has abdominal surgery, or somebody who got shot in the stomach, or had their diaphragm nicked or whatever with a knife or whatever the problem is, some kind of disease process. Because the diaphragm, I'll say for lack of a better term, is sparked by a nerve called the phrenic nerve, P-H-R-E-R-N-I-C, the phrenic nerve, okay? And if it comes from the brain, it sends a signal to the diaphragm to flatten. As the diaphragm flattens, it draws the lungs open, okay? The lungs don't inflate by themselves, okay? When we take a deep breath in, our diaphragm flattens and the negative pressure pulls air into the lungs, okay? Because the pressure inside the lungs is lower than the pressure in atmospheric pressure, right? So that's the physics behind it. Gas and liquid always travels the path of least resistance, okay? So I tell my students, air likes to run away from trouble, right? Run away from resistance, okay? Or pressure. So as I take a deep breath in, my intrapleural pressure drops, okay? And it becomes lower than the atmospheric pressure. So the air has no choice but to come into your lungs, okay? Now, when I exhale, my lung pressure becomes higher than the atmospheric pressure. So the air has to then run away from that, right? And come back out of the air out of your mouth. That's what's happening in the lungs. Your lungs just are there, okay? They don't physically inflate or deflate. Your diaphragm drops and forces them to inflate. And when the diaphragm releases, the elasticity in the lungs allows them to recoil, okay? Now, there are a lot of diseases to where the lungs are unable to recoil, okay? And the number one disease is emphysema, okay? Emphysema lungs are lungs that have lost their elasticity, okay? I tell my students it's like an old pair of drawers, okay? If you have an old pair of boxers that when you hold them up, they just stay open, right? They have the elastic band is gone, okay? Or an old rubber band that's been stretched for a long time and no longer has a snapback, okay? I kind of show them the difference between a broccoli rubber band, you know, the rubber band that comes on broccoli side, the real thick, real strong rubber band that comes on broccoli. That's how the lungs start out, okay? But over time and damage from like smoking, bronchitis, any other kind of obstructive lung disease can cause the lungs to lose their elasticity, okay? So now they're unable to force the air back out, okay? Now, since that's the case, what starts to build up in the body, right? CO2, carbon dioxide, because that's what we exhale. And if we're no longer able to exhale, we start to build up the CO2, which is an acid, okay? Carbon dioxide is an acid, and it forces the pH of the body to drop, okay? The lower the pH, the more acidic the body is, and you go into respiratory failure, all right? So if the patient cannot inhale, then we have to inhale for them. I'll get to the positive. Here goes the positive pressure. Now, the reason we give positive pressure, the number one, we said because the patient can't inhale deeply themselves, okay? Or inadequate vital capacity to facilitate a cough, okay? When you cough and I cough, we have to first take a deep breath and cough, right? We don't just, right? We don't cough like that. We have to be able to generate enough force behind the cough in order to expel the sputum and the mucus that's in the airway, okay? So if a patient cannot do that, we have to give them positive pressure. Now this IPPB, what you see right here, is a modality called intermittent positive pressure breathing. Intermittent positive pressure breathing, all right? And it's giving the patient positive breaths, okay? Before you have to put them on full-fledged ventilator, we can start out with this. Now, the young lady you had on earlier was talking about doing something less invasive, right? Doing something, giving somebody the ventilator that's less invasive. And you can do that, okay? We can give the ventilator without putting the tube down your throat, all right? That's called intubating, right? Now, yes, we can give the patient those positive breaths without putting the tube down the throat, being so invasive, which can cause infection, which is called ventilator-assisted pneumonia, right? It can happen, especially if they're not cleaning, keeping the mouth clean and all those things, because the way she was saying it, if it was a lack of care to the patients while they're on the ventilator with the tube down their throat, then all kind of things can happen. Because if they're not caring for the mouth, then the nasty mouth germs start to trip down into the lungs.
Now, remember, she said not all hospitals. She was just telling you the ones that she knows. She said the ones that's in New York. And so she cleared it. She said, now, I don't know about the other hospitals, but I know what they're doing over here.
Yeah.
And they are showing the lack of care and concern for the patients that's in these hospitals over here. That's what she said too. Go ahead, brother.
Okay. And that, like I said, and if that's happening at any facility, then the domino effect starts to happen. Because if I have that tube down your throat, it goes through the vocal cords into the trachea, okay? It rests about 3 centimeters away from where the lungs, where the trachea bifurcate into the right and left main stem bronchus, okay? And so that's right down in there. Now, if I don't keep the patient's mouth clean, oral care, moving the tube left to right to make sure that the patient is being cared for, then those infections, those diseases, not diseases, but those bacteria of the mouth, you know, our mouth can get extremely nasty. That's one of the most nastiest places on our bodies. And those secretions in the mouth start to go down the tube and around the tube into the airway, causing more and more problems, okay? So yes, we can give a ventilator non-invasively, okay? Because sticking the tube down the throat is called invasive, all right? Because it's going into the body. Now, we can give it non-invasive, but there's some problems with that. First of all, you can't ventilate as well with a non-invasive mask. The mask is a short-term fix, okay? Somebody who comes in short of breath, needs a breathing treatment, or that didn't work, now I need to put them on some type of positive pressure because they can't get the air in. So I force it in, okay? It starts to eat away at the bridge of the nose, okay? Everybody has a different facial structure, so it starts to leak. There's a lot of leaks around the mask. Some patients have feeding tubes in their nose, so you can't get a seal with a mask and a feeding tube. So the mask is a great idea, but it's short term. All right. And it does not ventilate the patient as well as being intubated. Okay. We can totally control your pH and your CO2 better when you're intubated. Now, a lot of the patients that you're coming in now that are coming in sick as they are, they pretty much go past that. Once you need to be intubated, you need to be intubated. And a lot of times we as therapists don't wait till you cold, right? We don't wait till your heart stops to intubate you. If we see you are going to respiratory doom, right? You're becoming impending respiratory failure. All the modalities have not been working. Your pH is dropping. Your CO2 is creeping up. Your work of breathing is creeping up. The patient's breathing hard, sweating, panicking, right? You can't do that for long, Si. You will pass out, okay? So we have to say, hey, we need to go ahead and take action and intubate this patient till we fix the problem, okay? Once we fix, or the doctors fix the problem, then we can start weaning them off the machine. Now, another reason why we give positive pressure is, like I said, their vital capacity is less than 3 times their predicted tidal volume. Our tidal volume is the normal air we breathe in and out. Just as you're sitting there breathing right now, you're breathing in and out your tidal volume. And to be considered normal or healthy lungs, you should be able to generate 3 times that amount if you need to either take a deep breath or to cough, okay? Because clearing the airway is paramount to your respiratory hygiene, okay? Your bronchial hygiene depends greatly on being able to clear your airway from your lungs, okay? From all of the mucus that gets built up in the lungs. So those are some of the reasons. It's the same thing there. All right, secondary. Sometimes we do it to give medication, aerosolized medication that needs to be penetrated or deposited farther down the tracheobronchial tree. Now, when I say that, so I'm talking about the trachea, starts here, okay? And then it bifurcates into right and left main stem bronchus. Then it continues to bifurcate into bronchi, then bronchioles, terminal bronchioles, and then finally respiratory bronchioles, where gas is exchanging. Those are the little sacs, the alveoli. The little bitty millions of sacs you have in your lungs are called alveoli. And that is where oxygen is fed into the bloodstream and CO2 is fed back into the alveoli so we can blow it out, right? It's an exchange. You give me the oxygen, I'll give you the CO2. You give me the oxygen, I'll give you the CO2. That happens with every single breath, okay? Now, sometimes we want to push aerosolized medicines farther down the lungs that we can. And we can do that with positive pressure, especially if the patient is not able to take a deep breath, okay? Because they may have got cut, they have an incision by the diaphragm, which makes their respiratory drive weak, or it hurts, like a couple of broken ribs. You don't want to breathe hard and you got 2 broken ribs, right? Sometimes we have to force that air in, okay? We can also improve our I to E ratio, which is our inspiratory to expiratory time. Improve or mobilize secretions, like I said, to be able to cough out those secretions. Alter your VQ. Now, your ventilation to perfusion mismatch is the #1 reason we put people on the ventilator, okay? We have to be able to do this. Like I said, when the capillaries give the alveoli the CO2, the alveoli will give the capillaries the O2, which is oxygen, right? To take it back to the body, because the body has to be oxygenated. Now, with this COVID-19, the alveoli are being affected, okay? Affected. I told you on the last time we were talking that it is destroying the type 2 alveolar cells. The alveoli is made up of 3 cells. Type 1, which allows for gas diffusion, right? That allows the oxygen to leave the alveoli, go into the bloodstream. It allows the CO2, which is the waste product, to leave the bloodstream and into the alveoli so you can blow it out, all right? Now, type 2 cells are Clara cells that produce surfactant. When I told you that last time, surfactant is like a phospholipid, it's like almost soapy, like detergent-like liquid that allows the lungs to stretch, okay? Without that, the lungs become stiff. And if I am forcing air into some stiff lungs, then I start causing the problems, okay? And these are the problems. All right. One of the problems is a tension pneumothorax, okay? An untreated closed pneumothorax. That is when I pop a hole in your lung, okay? If I am forcing positive pressure into your lungs and the surfactant is down and the lungs do not want to stretch and I'm forcing the air in, I can pop a lung, okay? Now, this is, if you can see can you see my mouse?
Yes, yes, we see it. Right there with the air, yes.
Yeah, okay, cool. When I force air down the trachea, right? Forcing air in, and then these are holes. It's like this will be indicative of a hole here. If I have a hole here, then the air comes out of the lung and hit the rib cage. It has nowhere to go, okay? So since it doesn't have anywhere to go, it comes back toward the lung. That's what those arrows are showing you. That air that was leaking out of the lung that I am positively forcing into the lungs can leak out, all right? If it leaks out, it hits the rib cage. It has nowhere to go, so it has to force that lung collapsed, okay? You see that? It pushes this lung here flat, causes collapse. Not only that, but it starts to deviate the rest of the organ. So it starts to push the heart over even farther, see? And after that, if I don't fix this problem, then I will start to collapse this left lung as well, okay? And that will kill you, okay? That can kill you if untreated, especially if you're not being monitored correctly, okay? Now, how we fix this? Chest tube, right? We'd have to do an emergency chest tube, which we will put a hole in your rib cage and put a tube in here to release that air, okay? As that air comes out of the tube, the lung opens back up and you're fixed, okay? Now, but if that's not happening, guys, it can kill you. So that's one thing can kill you, okay? Forcing positive pressure into some lungs that are not willing to stretch. And we call that having a low compliance, okay? Surfactant regulates the compliance of the lungs. When something has a high compliance, that means it'll do whatever you tell it to do, right? If I tell the lungs to stretch, they stretch. No issue, right? Good compliance. If I tell you somebody's taking their medicine like they're supposed to, they're compliant. They're doing what you ask them to do. But when the surfactant level is low, the lungs become less compliant, right? They do not do what you tell them to do, right? So now I'm trying to push air into a lung that refuses to stretch. And if I'm not careful, then I will pop a lung, which is called a pneumothorax. And you see what happens with a pneumothorax. That's this part, okay? So that's one contraindication of positive pressure. We got to be careful because this can happen, all right? This is an x-ray of that same situation, which is a tension pneumothorax. Now, in an x-ray, air is black, okay? But it shouldn't be so black that you don't see the ribs. So if you look over here at this lung here, okay? This is the right lung. Now, I know you're looking at the left side of the screen, but when we are in anatomy, we have to go by the patient's left and right, okay? So this is the patient's right lung, okay? And this is the patient's left lung over here. And this is the heart, okay? This is the heart. With that same tension pneumothorax, now you don't see the the rib markings right here. It's so much air in there, you can't see the ribs. That's bad, okay? Not only that, but it's pushing the heart and the other lung over to this side. That can kill you if we don't get a chest tube inserted, okay? So that is, like I said, that's one way that a ventilator can kill you, okay, if you're not watching the patient. All right. Also, we have to be careful with positive pressure because people have head injuries, right? ICPs are intracranial pressures. Anybody who has, if you ever had a family member that had a bad wreck or had a major traumatic brain injury, sometimes they have what's called a bolt coming out of their head that measures the pressure in the brain. Because when we push positive pressure into the lungs, we make more pressure in the head, okay? And so if the head is already very sensitive because of the injury, then we have to be careful not to force more pressure on the head than the brain can take. And so that number is a set number. ICPs greater than 15 millimeters of mercury, we don't want to do positive pressure. Okay, we have to watch that. If somebody is hemodynamically unstable. Now, this is where I want to really harp on. Hemodynamics is pressures inside of the body, right? We're talking about central venous pressure. We're talking about blood pressure. We're talking about pulmonary capillary wedge pressure, pulmonary artery pressure. All of those things are called hemodynamics. And that'd be a whole nother lesson, okay? But the bottom line, as you heard, you understand, is blood pressure, okay? And high blood pressure is bad, but low blood pressure is worse, okay? If I can't keep your blood pressure high enough to sustain life, you're going to die, okay? Now, like some of the patients who are in ICU, they're on what's called a drug called Levofed. If anybody ever heard of that, in some size guests, I think I've heard somebody talk about Levofed medicine. That is a medicine which is it's kind of like the last ditch effort to keep somebody's blood pressure high enough to stay alive, okay? When we were in school, they said Levofed, leave them dead, right? It's kind of like if you have to put them on Levofed, they almost gone, all right? So
real quick, time out.
Go ahead, bro.
I want everybody that's listening right now, we are in school, we are in class. Please write down some real serious questions so when we open up the lines, you can ask the brother some questions pertaining to what he's talking about. So be ready, write it down. Go ahead, my brother. Continue.
All right. So I heard somebody, like I said, somebody was talking about Levofed, which is a medicine that keeps the blood pressure high enough to sustain life. Because if it gets to a map below 60, it's harder for them to stay alive. The blood has to have pressure to circulate around the body. If the blood pressure is too low, it becomes stagnant and the body cannot get its nutrients, its oxygen, and all of that and get rid of its waste, okay? Because the blood that comes to the heart, okay, from the body is full of waste, right? It's full of waste. It comes into the heart to get pumped to the lungs, and the lungs can exhale the waste, all right? But at the same time, the lungs inhale fresh oxygen that gives back to the blood, right? And goes back to the heart to go back to the body. All this is happening with every beat of your heart and every breath of your lungs. So the heart and the lungs work hand in hand. So that's why they usually call respiratory therapists, are usually called in some places cardiopulmonary therapists, because you can't do one without the other. And so what's important is this: positive pressure has some effects on the blood pressure, okay? When we introduce positive pressure, we can decrease the venous return, okay? The oxygen, the blood that's coming from the body comes back into the heart. I wish I had a heart with me, but I think I have another show here too. But the heart receives blood from the body, right? But if I'm giving you positive pressure on a ventilator, it restricts how much I can receive. So think of it as if you're stepping on somebody's heart, okay? You got a heart and you're stepping on it, right? Well, it can't receive any blood if you're stepping on it, right? But at the same time, if you can't receive the blood, then it can't pump the blood. So that makes the cardiac output diminished, okay? And that is indicative of blood pressure, all right? So if somebody is in a hypotensive crisis, which means their blood pressure is extremely low, and they're on medicines to keep up the blood pressure, and without the medicines, they would surely die because of hypotension, okay? Well, if I am adding to that hypotension with positive pressure, it's a two-edged sword, okay? Because I'm pushing in positive pressure, which may drop your blood pressure if I'm not careful, okay? And if you already have a low blood pressure, then I could make it worse. So it's going to be more medicine, less pressure. I may even try to alleviate some of the pressure I'm giving you by giving it to you in short breaths, but faster, okay? If you've ever seen a baby on a ventilator, the ventilator is like this. It's really, really fast breaths, but low volumes because their little lungs can't take the volume, right? Can't take that volume, but you have to make up that low volume with faster rate, okay? Normal adults, we do about 12 breaths a minute and about 500 tidal volume. That's a normal lung, okay? Normal lungs. But if my lungs have been affected by corona or whatever disease, not just corona, right? Because people have died from being on a ventilator before corona, and they're going to die after corona, okay? But they're also going to live because of the ventilator before corona and as well as after corona. So I'm not basing this just on corona. I'm talking about the physiological effects of positive pressure on the lungs and the body, okay? So we have to be careful because we can drop the blood pressure with the amount of peak that we give and the amount of pressure that we give, okay? Now, a lot of our patients who are sick now are dying because of low oxygen, okay? We can give you all the oxygen in the world, but sometimes that's not enough. We have to add what's called PEEP, okay? And that is positive end inspiratory pressure. Let me get to these pictures here. Now, this is the picture of the boat I was talking about. These are some gentlemen who are very, very ill from a bad injury. They have a lot of pressure in the brain, okay? So if I have them on a ventilator, I have to be mindful of how much volume and how much pressure I'm giving them because I may make them brain dead because of the pressure, okay? Not only that, but I could cause a hole in the trachea, okay? This is a tracheal esophageal fistula, which means there's a hole, this right here, and then this is the trachea, okay? This is what your trachea looks like from the inside, okay? And this hole here is a hole that would lead to your esophagus. The esophagus is behind your trachea or posterior to your trachea, okay? And if I'm blowing air into your lungs and you have a hole right here, now the air's going into your stomach, okay? And it's causing gastric distension, which may even make you aspirate your stomach contents into your trachea. And that is called aspiration. And aspiration can cause pneumonia, which is aspiration pneumonia, very deadly. Anytime the hydrochloric acid and the contents of your stomach get into your lungs, that can cause a whole nother set of problems. You see what I'm saying? So it's more of a domino effect if you're not watching, can be the demise of a patient on the ventilator, not necessarily just because they on the vent. Because if anybody who watching us now, and you sit around and you're watching TV, then all of a sudden you can't breathe, okay? You can't generate a breath. You're not gonna say, well, don't put me on the ventilator, right? You want whatever it's gonna take to push air into your lungs till you can figure out what caused you to have that problem, okay? And like I said before, we can start with non-invasive, but the patients that we're dealing with have a disease that if I have you on non-invasive, then when it leaks out your mouth, the side, when your mask leaks, it leaks into my face, okay? It leaks into everybody that's around the patient. So the best way to contain any kind of viral or bacterial load that's killing the patient, if we're ventilating them, is to have it sealed with a tube, okay? We put the tube down your mouth, your throat, I'm sorry, and we inflate the little balloon around the tube to seal it so air does not come back out of your mouth, right? It's not leaking around the mask. They're not taking the mask off and breathing in everybody's face, right? That's a hazard. That's a major hazard. So we try to contain not only COVID, but tuberculosis. If we have a patient who's on a ventilator because of tuberculosis, they're not going to be on a non-invasive mask. And you wouldn't want them to, because tuberculosis is an airborne disease, not even droplet. It's airborne. And so if I, as a respiratory therapist, have somebody who has COVID on a non-invasive mask, and I'm giving you a breathing treatment too, then now those aerosolized particles that I'm pushing down your throat to give you medicine with also pick up the disease. And they are aerosolized now and coming back out of the side of the mouth, because some patients have dentures. Some of them don't have their dentures in. Some people have longer chins. I mean, the mask is either small, medium, or large, right? And you have to try to pick the right mask for the right patient. But it's so many leaks. It doesn't ventilate as well. It's temporary. It's a great thing for temporary use, but somebody who is very sick gonna be on the vent more than temporary. So why skip and play with the temporary and risk other people around you, as well as you not getting what you need to live? So we go straight to intubation, where we can seal off the trachea, and none of that stuff in the lungs can be aerosolized because of the vent. All right? Because the ventilator has internal filters that the exhale gas that comes out of the lungs through the tube goes immediately through a filter, okay? And it catches and kills everything, all right? And so it does not escape to outside air, all right? So the tracheoesophageal fistula was another reason why positive pressure is dangerous, all right? Blebs or bullae. These are called blebs, all right? Positive pressure or putting somebody on a ventilator can force little pockets of the lungs to pop out. Okay, you see this right here. I tell my students it's like the lungs blowing a bubble, right? If you ever chewed some gum and blew a bubble, right? Well, that's what this is. Either the compliance or the surfactant, something could be wrong in the lungs, or just too much pressure. You got a doctor or a respiratory therapist who put too much pressure in the lungs, and you're causing it to pop little bubbles like this, right? But as long as it stays like this, it's very painful, but it's not a hole yet, okay? But if you keep blowing that piece of gum, right? You blow your bubble and keep on blowing it, it's going to eventually do what? Pop. And once it pops, air then shoots out of your lungs, causes a collapse and all kind of problems, which could lead to death, all right? So these are, right here is a normal lung. Okay, this over here is what we say a bleb. This is a cross section of the blebs, or also bullae. When it's more than one bleb, it's bullae, right? If I'm not careful, one of these bubbles will pop, which lead to collapsed lung because of the pneumothorax. Okay, so this is the animated picture of it, and this is actual blebs on actual lungs here at the bottom. Okay, just like a bubble. Right? Just like, or if you had a boil, anybody who's had a boil, that when it comes to a head, the skin is real shiny and sore until it pops, right? That's the same thing happening in your lungs. And this happens because of positive pressure, right? And the ventilator generates positive pressure, all right? But the thing is like, we have to look at it. Yes, positive pressure can be dangerous, but it's also life-saving, because there's so many people who go on the ventilator who live, who we wean, and if without it would have died, okay? So as a clinician, I would tell you, if it was my mama and she needed to be on the ventilator, knowing what I know, of course, she's gonna be on it, but I'm gonna watch it and make sure everybody don't have that. You know what I'm saying? Like the young lady said, you don't have family. If they think you have COVID, you don't have family. Right? You don't have anybody in the room to come see you, right? It's only the staff. And yes, some places staff can be I'm glad her mama ain't there, or I'm glad her daddy ain't here because they be asking all these questions and I don't feel like answering. You got people like that. You do. And it's unfortunate that that's the case. But the bottom line is, physiologically, if you can't breathe, you have to have positive pressure or die. That's your choices. Okay. Now, when we get you on positive pressure, we have to be mindful of the hazards and the thought that you can be addicted. Because once the body say, oh, you gonna breathe for me? Oh, well, go ahead, right? And then I take the tube out, body don't want to breathe because you've been breathing for me for 3 months, or somebody been on the ventilator for 2 weeks, 3 weeks, and you're gonna breathe for me every day? Well, go ahead. And as soon as you take me off, I ain't gonna do nothing. That's what the body can do.
That's deep right there, brother. That's deep right there, man.
That's what can happen. So, and just like oxygen, because the body gives the oxygen, right? You breathe it in and the body gives it to the bloodstream. The lungs give it to the bloodstream. But if I'm giving you oxygen for years, you got people who've been on oxygen for years. And if I take them off, their oxygen levels drop because their body is so used to you giving me oxygen. It's like pain medicine, right? You keep on giving it, you're going to need it, right? It's addictive. And so the body gets used to you breathing for it. All right. So if you're giving somebody full-fledged ventilation for, it usually takes a while to be addicted. Somebody been on it for a good month, 2 months, something like that. It's very hard to get them off, especially if they have underlying conditions like COPD, asthma, right? Emphysema, bad reoccurring pneumonia, stuff like that. It's already hard for them to breathe now. And so when you put them on the ventilator, you have to think, hey, this patient may never come off, especially our older patients. See what I'm saying? When we got an older patient who's been smoking for 50 years and they have an exacerbation and they come to the hospital and need to be ventilated, we think about that. We say, we want to put him on, but if I put him on, he's probably not going to come off. And not to say he's going to die on it, what I'm saying? It's going to kill him, but he's probably not going to be able to breathe without it once I give it to him, because his body has adjusted to struggling for so long, okay, that now that I give it, the glory and give it some ventilation, you can hang it up. A lot of times it is hard to get those patients off. All right, it is. It just is. But it's like, what do you do? You know what I'm saying? Do you just sit there and can't breathe? Or do you take the ventilation and hope that the staff is watching all of these parameters so that you're stay healthy, like they do it in most hospitals? The doctors at hospital, they round every day. They're watching. You have respiratory therapists who are managing the ventilators, right? You have your nurses who are making sure they're giving the right medications, and everybody's a team. That's the ideal, but with this situation, with lack of staffing and scare and fear and paranoia, who knows what's really happening in some of these facilities? We don't know, right? We really don't. But to say that, the ventilator is flat out killing you is silly, okay? It's silly. You can't do that. You can't do that. And I wouldn't advise you to say, all right, now something happened to me with this COVID or any other disease. I go out here and have a car wreck. I don't want you to put me on a ventilator, okay? Because once you say that, it's in stone, all right? And I don't care if it's your mama, I don't care if it's your wife. If you are sane in the mind and you write down you don't want to be ventilated, you will not be ventilated. If you are insane in the mind, I'm not insane, but if you are sane in the mind and you write down, hey, I don't want to be resuscitated, then you won't be resuscitated. I don't care how much your wife crying, how much your daughter is crying. If you are in right mind, before you ever get sick, write a will or testament and say, I do not want to be resuscitated. Then we have to go by those wishes. We have to, because we can be sued if we resuscitate you. So we bring you back to life and you say, damn, I didn't want to come back to life. I'm suing y'all, right? And you're going to get sued. So we have to honor those wishes. We have to. So be careful in those decisions before you make a fly-by-night decision like this about ventilation. Because if you say you don't want it, you won't get it, okay? And, it's sad, but ethically, we can't go against your wishes. right? So barotrauma, which is another complication, that is damage to the lung, which leads to pneumothorax. A pneumothorax is a hole in the lung, okay? So the blebs, excess pressure, barotrauma, all these things can lead to popping a lung, all right? Which can happen with positive pressure ventilation, okay? They can also get nosocomial infections that can kill you. And nosocomial means hospital-acquired infection, right? You run a higher risk of becoming infected with hospital-acquired infections by going on the ventilator. That's just the truth. That's just the truth. Hypocarbia, which means we take your CO2 too low, right? We can take it too low if we're blowing too much volume in you. Right? It's a science. There's normals to pH. There's normals to carbon dioxide, which is CO2, right? There's normals to oxygen, that we have to keep it normal, right? And we get blood, respiratory, goes to the artery and draws blood called an ABG. And we read your pH, we read your CO2, and we read your oxygen, right? And we also read your bicarb, which is your metabolic status. And we make changes to the ventilator to fix it, all right? It's respiratory that goes in and gets that blood. It's respiratory that makes the changes on the machine to fix that, all right? Without somebody fixing it, you would go into such a deep acidosis or such a deep alkalinosis that the body cannot survive, okay? It can't be too hot, can't be too cold, right? It can't be too acidic, it can't be too alkaline. It has to be homeostasis. And when it comes to arterial blood gases, respiratory and the doctors manage the ABG with the ventilator, okay? That's how we control it. Now, when you start waking up and breathing on your own, then you start controlling your own ABG, and we give you less support. So we give you full support. You wake up a little bit, sorry, you wake up, then I can take some support away. And then you looking around, you answering questions, I can take some more support away, right? And then you really say you ready to come off, I disconnect you. See, can you breathe without it? I leave the tube in, but I see if you can breathe without it. If you can, now we're ready to pull the tube, okay? But so it's a process, all right? It's a process, but it's necessary. The ventilator is necessary. Let's see. I had another. Now, this is what's important. Another thing that's important. Oxygen-induced hypoventilation in COPD patients, okay? If I have a patient who has COVID that also already had COPD, who needs a lot of oxygen because of the disease, but doesn't need oxygen because of his prior disease, it's crazy, because somebody who has COPD cannot have too much oxygen. If I give them too much oxygen, they stop breathing, okay? So, so you have to think about that. I have a patient who's been smoking 50 years, 40 years, and he has COPD. Well, I want his oxygen level to be kind of low. I don't want him to have 100% saturation. If I give a COPD patient too much oxygen, their body will say, oh, okay, well, I ain't gonna breathe, and stop breathing. Now, think of that same COPD patient contracting COVID, which now his oxygen level is so low, we do have to give him a lot of oxygen. So now we are trying to wrestle with, am I going to give them too much, or am I not giving them enough? Am I giving them too much, or am I not giving them too much? See, it's a real tug of war with certain patients. And I can also know if you have COPD for a real long time, and I put you on that ventilator, you might not come off. So it sucks, but that's the part of it. It's a two-edged sword, most definitely. I'm not saying that the ventilator is the cure-all, and you go to the hospital, ask for the ventilator. I'm not doing none of that. And whatever your wishes are, that's your business. Okay?
Remember the doctor that I played like about a couple of weeks ago? And he was saying the same thing about the ventilator. He said that he feared that they were using it inappropriately. See, the way you dropping it now, you dropping it, letting them know that this is a science, that you got to know what you're doing with these ventilators. I appreciate the way you dropping this information. and the people should appreciate it. And let's show them some love and throw these. Let's like this video. Hit the likes, y'all. At least it's free, you know. So the people can get this notification and see these videos. Make sure y'all share the video as well. Share it on your Facebook, because, you know, there's a lot of things going on between the ventilators. Should we use them? Should we not? And the doctor straight up said, and, you know, they took him off. They took him out of that room. They no longer using him because they said that we can't no longer use your services if you're going to be going against what we're talking about. So that's deep right there, brother.
Yeah,
you know
yeah.
So go ahead, continue, brother. You going in?
Yeah, that's deep, bro. That's why I say it's a science, guys. It's not just I don't want no event and I do want an event. It's a science. You got to know, you know, we have to know the condition of the patient. We have to know the previous conditions of the patient. We have to know, are they going to be more susceptible to being addicted to the ventilator, or are we going to have somebody who may be very successful? But what's really killer about it is because when you get to the point where you need a ventilator, it's either you gonna get it or you not, right? It's not a, well, let me think about it. You know, it's not a, well, we'll see. Let's see how we feel tomorrow. When you can't breathe, you can't breathe. And if you can't breathe, you can't ventilate, you can't oxygenate, and you will die from respiratory failure. We have to give you some ventilation. Now, that same ventilator can be either invasive or non-invasive, right? It's the same machine. It's just the mask or the tube, right? Same machine. There's nothing different about it, right? We can give you invasively or non-invasive, but that's not going to last long. When somebody comes in for something else, like a bad asthma attack or overweight real big, and they're, you know, they're having some obstructive sleep apneas and stuff like that, we can give you non-invasive positive pressure and help you out, right? Till you get you right, you feel a little bit better, we can remove the mask, you good, right? Give you some prophylactic medication that will keep you from having this problem later, as long as you're compliant with the medication. But when you are in a critical point, right? When you become in critical condition, there's no question whether you need the ventilator or not. If you are critical and you cannot breathe and your CO2 is increasing, we are going to intubate you unless you say you don't want it. But then if you don't want it, you're going to die. That's as simple as that. Because I'm not saying that if you don't get a ventilator, you're going to die. Don't misconstrue that. I'm saying if you get to the point where you have to have somebody breathe for you and you say don't do it, the only other choice you have is to die. All right, that's the bottom line. But if the people are not using it correctly, it can cause some problems. If you don't know what you're doing and you are doing a one-size-fit-all ventilation approach, then you can cause these problems I've just showed you. I just showed you some things can happen if you give too much pressure, right? There's different modes on the ventilator that we can accomplish different features, different ways of ventilating. But you got to put it in. You know, you got to have somebody who's doing, yeah, pulmonologists, respiratory therapists are the ones who are dealing with the ventilator. Okay, that's it. And so if you have knowledgeable respiratory therapists and you have good pulmonologist MDs on your staff, you should not have any problem with the ventilator, because the RN's gonna do their thing, right? The nurses, they're gonna do their thing. They're gonna make sure you got the right medication. They're gonna make sure your hemodynamic status and all that stuff is right. They're gonna make sure you're fed. They're gonna make sure you're baked, clean, all of that. But when it comes to breathing, that's respiratory, that's pulmonology. And you have to make sure you have a knowledgeable staff that are taking it serious, because if it's a one size fit all, you're going to kill all. Okay, that's the bottom line. It can cause decreased cardiac output, right? I'm showing you some negative things about positive pressure. I'm not hiding it. I'm telling you that these things can happen, which means your heart does not pump out the same amount of blood that it would have before the positive pressure, because it's just one of those things. Is positive pressure can decrease cardiac output. All right. So we have to be mindful of that. We have to be careful when we make our choices for the settings that we set. All right. We can cause you to cough up blood. That's what hemoptysis means. Start coughing up blood, right? Because you might have bust some little vessel. The air may have busted some little vessel in the lung that's causing you to cough up blood, right? And if you choke on that or or inhale that, it's aspiration pneumonia, right? So that's a thing that can happen. Hyperventilation, which is the same as blowing off too much, right? Hyperventilation is when you blow off too much CO2, right? The CO2 is a waste product. It is an acid, and it does have to be expelled, but there's a level. It can be, you blow off too much, you fall out, right? You ever seen somebody outside that was having a panic attack and they were breathing real fast, real fast, panicking, and we take a paper bag and put it over their face to slow them down? If you ever saw that or heard of that, that's because they're blowing off too much carbon dioxide. And if we don't catch it, they're gonna pass out, right? So we put the paper bag over their face as a makeshift catch-all, right? And it will catch some of that CO2 from being expelled and they won't pass out. That's why people pass out when they hyperventilate, because they're blowing off too much carbon dioxide, all right? So we wanna keep the carbon dioxide in a good level. We want to keep the oxygenation at a good level, and we want to keep the pH at a good level, all right? That's how you stay alive on the ventilator. And if I know you're having high pressures in the lungs, I need to switch my ventilator to a pressure control mode where I don't go above a certain pressure and I don't no longer risk popping a lung, right? So it's very important. It's a science. And like that doctor said, if they're not doing it right and they're just trying to do one size fit all, you could have a lot of problems, guys. So I just want you to have the information on hand, okay? Because hyperventilating, I can cause dizziness, I can cause them loss of consciousness, tetany, and paresthesia, okay? And paresthesia is when you have decreased CO2 in the brain, right? Decreased cerebrovascular CO2 because you're blowing off too much, right? And so when that happens, it causes vasoconstriction and decreased cerebral blood flow. That's why you, boom, fall straight out, right? So somebody who's breathing real fast, panicking, right? Or if I'm blowing too much in you, if I'm giving you too much volume or making you breathe way too fast on the machine, I can cause you to lose consciousness, right? So it's important that we are giving the right rate, the right volume for the right patient. And that's knowing how old your patient is, how tall they are as far as their lungs, any kind of preconditions that they may have had, some kind of sarcoidosis, some kind of fibroids in the lungs, COPD, if they have restrictive lung diseases, neuromuscular like myasthenia gravis, Guillain-Barré, other kind of restrictive diseases, polio, things like that can cause me not to be able to get the air in, okay? And so we can pop a lung if we do too much. Some of these doctors or some of these people may be overzealous and trying to be, heroes and maybe doing some damage, all right? But that's the practitioner and not the machine, all right? Be careful not to blame the machine for something somebody that didn't know what they were doing was doing, or just didn't follow through, guys, because of lack of staff, lack of, and so much fear and paranoia. We can't forget about that. When you're scared to go in the room, you're not gonna stay in there long. If you think this person might potentially make you take some stuff home to your babies, right? You don't stay in there long. You don't want to go in there, first of all. And when you do go in there, you're going in and out. You're not watching all the little things that you should be watching. And so we have to protect ourselves and not be so paranoid, because that paranoia can cause a lack of care, right? And that lack of care, you don't play with a machine like a ventilator. It's very intricate. It's very scientific. If you can't just play with that, okay? You can't just make this change and that's it. You have to watch it. That's why you either gonna love the job or you hate the job. It ain't for everybody. Like teaching, there's no way in the world that I could teach young kids. I could teach grown folk, but young kids, I love them, but I don't have the patience. I don't have the patience for that. But teachers that do it, hey, they love it. So you either love what you're doing, y'all, or you doing it to get a paycheck. And if somebody's doing it to get a paycheck, running to New York to try to get that extra $5,000 a week, some respiratory therapists are making $6,000 a week in New York right now because of the shortage. right? Because of such a shortage, because people don't want to come to work. They scared. And so if you're making all that money, staying in the nicest hotels, and if you're not going in the rooms and really dealing with these patients, they're not going to benefit from the therapy.
Have you thought about coming through to New York?
Well, I thought about it, but you know, I'm in two different spots, and I just can't. I don't have the time. But if you know something was to happen, brother, and I lose my jobs here or something like that, and then you know, Corona just takes over, and I have no way of making income, I'm gonna do whatever it takes to feed my family. But you know, right now, I'm Lord willing, I've been blessed to be able to hold on to the teaching. We're teaching online, so the hours have been cut, but we're still working. I still have some benefits and stuff like that. So, you know, I just want the family to be able to see the effects of actual ventilation. Okay. And it can have hazards. It can have some things that are domino, but it's more on the, you know, if you're not really watching and you're trying to do a one size fit all approach to ventilators. No, so like we was talking about the addiction, right? Yes. If your body gets used to you doing it, just like anybody else, just like anything else, you get used to somebody doing something for you and they stop doing it, you die. You know what I'm saying? You're like, wait a minute, dang, you got to come back to getting used to doing it yourself, right? Everybody gets comfortable, right? And the body, just like anything else, can get comfortable with the machine doing all the work. And you start letting the machine do all the work, the body can not necessarily forget how to do it, but starts to shut down. It would divert that energy somewhere else, right? So I ain't got to breathe no more. Well, then let me focus that that energy to something else, like my hearing or my taste or my sense of smell, right? When we fast, when people fast and don't eat, the digestive system shuts down. Well, that energy and that energy from digestion goes somewhere else, right? That's why they say they can hear from God, or they get more in tune with things because their eyesight is better, their smell is better, their taste is better, all kind of things, because they're not necessarily using that system. So if it shuts down, that energy has to divert somewhere else. Well, if you breathe for somebody for 2 or 3 months, then it's sometimes when you take them off, the body does not want to do it. And that's what we call addicted to the ventilator. It's very true. That's very true.
How much more do you got? Because we can do a part two. We could do a part two, but if you ain't got that much, we can finish this off.
Yeah, we can do a part two, so I can ask any questions.
All right, yeah, we can do a part two, so you ain't got to overload them. You know what I'm saying?
Yeah.
So remember where you left off at. Remember where you left off at. So we're gonna do a continuation sometime this week coming up.
All right.
All right. I want everybody to know that I got Dr. Ali Muhammad tonight. Ali Muhammad will be coming in, I think, about 6 o'clock. And you already know what we're going to be dealing with. We're going in on the Rona. We're dealing with this. So Ali is in Atlanta, Georgia. So he will be bringing us some powerful information. I know you're going to be tuning in, Rob.
Oh, yeah, I'll be
all right. Yeah, tune in. If there's anything wrong, you can clear it up. But he will be in the night. So y'all want to see Ali Muhammad get it in. So are there any callers out there for our brother? Are there any callers out there, man? Let's get it in. It's time. Let's get these callers in, man. We got somebody. We finally got somebody that really knows what he's talking about. This is what he got a degree in. All right. So let's call it in. All right. Oh, where the calls at? Come on, y'all. Y'all finally got somebody in here that knows their stuff. Y'all should be lighting these phones up right now, man. See, that's what I be talking about. Y'all don't really want to know this information, man. People just be talking to be talking. All right, brother. Rod, you could be talking while we waiting on somebody.
Okay.
All right. I ain't calling in because she's around these people that deals with this stuff. I'm surprised she ain't calling in to add on to what you're talking about.
Yeah. And like I said, I don't claim to know everything. I just do know
right.
what I know, and I try to learn as much, when other doctors come, when I'm not a doctor, I'm a respiratory therapist. Doctors call in, hey, I'm willing to listen. Maybe.
All right, peace and Black Power family. What's your name? Where you calling from?
Yeah, this is JJ 7,000 People's Champion. How about Shimmy? How about
All right, what's going on, my brother?
What you should do, Saneter, because everybody got the cat got everybody tongue. Call all those ones that was talking all that stuff. Go call Garfield. Go call all of them so they can get schooled and educated right now. That's what you should do. You know what I'm saying? You put them on the spot. You got brothers in the field.
I feel you, but it's not about debating on that right now. So I want to just keep on the people who want to call in and ask some good questions, brother. I
good
feel what you're saying,
questions. Okay. Right, because now they hiding and ducking under the bed. When they got all this to say, because like I said, the brother is basically backing up everything that you've been saying.
Yeah, but do you have any questions for the brother?
Yeah. Okay, so basically, brother, I didn't catch all of the show, but the ventilator thing, are you saying that they're not, like, they cause like people to get backed up and they're not cleaning them properly? Because I've heard this before. So are you saying that the ventilators are basically was kind of getting people even more sick? Because I came in late.
You ain't see the show, brother. That's not.
I didn't see the show, sir.
All right, I'll let the brother respond to you. Thank you.
Yeah,
go ahead. You go ahead.
It's not necessarily the ventilator. I was showing you the physiological effects of putting positive pressure in somebody can have some negative effects, but it's mostly how it's being delivered by the practitioner, right? It's not a one-sided out. You have to monitor, you have to do other things to make sure you don't cause these problems. It's kind of like the gun, right? The gun don't kill nobody. It's the person who's
right. It's the person behind.
You know what I'm saying? And that's the main part about it.
So are you saying that in the nursing field that they're not training these people properly to actually operate these ventilators?
Well, I think some people are taking some places because of the pandemonium and the shortage. They're taking some, I don't want to say they just don't care. They're taking some some cuts. And like I say, it's respiratory therapists who deal with the ventilator. Don't deal with the ventilator. You do have some nurse anesthetists that are in school to be anesthesiologists that do deal. But as 98% of people who deal with the ventilator are respiratory therapists and the doctor, okay? And so I wouldn't say that they just don't care. I would just say, man, with the situation that it is, it's got to be, and they're learning, it being a COVID, a new disease, they're learning as they go, and they're trying to put best schooling they can put on it, on something they've never seen before. I can say that it can't do nothing but get better unless people are just completely negligent.
All right, thank you, Jeremiah.
All right.
So distro. All right, hold on, my brother King, for 1 minute. Distro.
Press 1. To send a voicemail, press 2.
All right.
Hold on, my brother King Simon, for 1 minute. Let me address distro. Distro, you are 100% correct. He says Saneter was the one yelling ventilators is killing folks. The guest literally said the notion is silly. Well, I stand on what I said, Distro, because you didn't really hear what I said. You are here to be a clown. You are here to be a distractor. What I said was what the hospitals were saying in New York. And I still stand on that because they said, and this brother clearly said, if they not being used right, they will kill you. The doctor came on and I showed where the doctor said he feared that they are not using the ventilators correctly, which is killing the patients. I said that. The other nurse that came on that I showed you, our European sister, she said that they are being mistreated. They are not being taken care of. They are being ignored. So I was right, Destroyer. What part you don't understand, Distro? You just a nut. I understand. Listening is an art. I'm not going to go crazy on you because I got the good brother here right now and I don't want to mess up the stream. So listening is an art. I stand on what I said. I make no apology on what I said. And I agree with the brother that I have on my show right now, 100%. Why? Because this is what he went to school for. This is what he got a degree in. So I can't refute what he's saying. He know more when it comes to this. Peace and black power to you, my brother. What's your name? Where you calling from?
King Simon, brothers. Hey.
Peace, brother King. How you doing, King Simon?
Peace, brother.
Great. I wanted to say, what's up, brother? Dr. Amin Ra, much respect to you. Thank you for all your services that you've been doing, being one of those frontline people. You know, and I wanted to ask, you know, I'm a disaster preparedness instructor for over 20 years now. When disasters and things like this, like pandemics and things like this happen, what about the stress factor of nurses and doctors at this time? Can that also cause people to misuse the respirator system, the respiratory system?
Most definitely. That's what I was saying. If you have people who are stretched so thin, you got patients,
yes,
respiratory therapists that have so many, dealing with so many, you're short staffed,
yes,
you're scared to go in the room, right? This is a new thing. Everybody knows that you have symptoms, and I mean, you can have it and not have no symptoms. They got families at home. So yes, most definitely not being stretched so thin and being afraid of what this new thing is happening, right? And then not knowing what it's actually physiologically doing to the body. We only been doing this for a few months, right? And so, you know, next time it come around, it should not be the same problems. But right now they're trying to throw everything at it, and they may be using a universal approach that's not working, okay? And so, yes, I think being so thin can definitely cause it to be misused.
Well, you know, I want to thank the people in the hospitals in New Jersey that took care of my uncle who's 81, and he's off the respiratory system. He's in the rehab now, and I just spoke to him. He did say they treat him all right, but, you know, because they're stressed, there's so much going on, and I grew up with nurses and doctors in my family. So thank you very much, brother. That's all I wanted to ask. I know to keep on doing what you're doing, my brother.
Thank you, King.
No problem. Thank you, brother.
You're welcome, sir. Thank you.
All right, come on, family. This is your opportunity. This is your chance to call in, learn something, ask the brother some questions. Teach us something if you can.
Because I'm willing to learn too. You know, I'm ready to learn.
There you go. Okay, so I don't think people really got too many questions for you. Now we got you in here, and they running from the questions. I don't get it.
On the next one that we do, so I can go over the heart. And I talked about the lungs. I can go over the heart.
Somebody.
All right.
Peace and black power, family. What's your name? Where you calling from?
Peace and love. Saneter is Carla Way.
Carla Way in the building. Well, how you doing, Carla? What's happening? You got a question?
Yeah. Well, I mean, first I want to thank Amin Ross for clarifying some things. He's actually on point. I do have a question.
Yes, sir.
Because would you agree that once it reaches to that stage that your lungs kind of sweat up like it's like a sponge, and that's what makes it difficult for people to actually breathe?
Mm-hmm. Oh yeah.
Okay.
The alveoli start to fill up with secretions because you're not ventilating. So when we ventilate and we take a deep breath in, we're able to mobilize secretions, right? But when you can no longer ventilate, that's a domino effect. Now the secretions start to build up. The edema inside the lungs start to build up. You cannot transfer oxygen and CO2 because there's water and there's mess all in the lung, right? So it can't transfer. And so it's like a domino effect. They go into acute respiratory distress syndrome. And if we're not ventilating them properly, you know, it's very dire. So yes, it starts to just fill up, just like you said, just perfect example, a sponge. And you can't occupy two things at the same time, right? So if my alveoli is full of fluid, then it can't have gas, right? It can't have the oxygen or the CO2 diffusing through the capillary and the alveolar membrane because of the stuff that's there. And since we can't take a deep breath, we can't mobilize that stuff and cough it up out of us, right? And since we can't, that, you know, domino effects, which end up a lot of times in death.
Right. So you would agree that at this stage, it's very slim that you guys have the ability to save them, correct?
Well, yeah, it depends on how soon they get on. When you see what we call impending respiratory failure, right? We don't wait till you get to a point where it's like, oh my God, they're about to code, let's intubate. We start to notice, right? If you're taking time with your patient, you notice impending respiratory failure from the ABGs, from auscultation, from x-rays, CTs. If they're not doing all these things to the patient, then you have no way to say that's the time to catch it, right? You might catch it too late, and you can be too late, right? If the lungs get to a certain point, so diseased, so damaged, you can be too late. But you have to do those diagnostic studies, those diagnostic steps to catch it, right? Have good eye to catch it. And then you try to get on the front end of it and not the back end.
Sister Nandi, you there? Carla, you still there? Wow. Okay.
That was a good analogy she used as a sponge. You know, soak up like a sponge. But at that point, you can still fix that side, and depending on other systems, like, because you know the disease attacks other systems, right? It ain't just the lungs. So I'm telling you how we deal with the lungs. But if it gets to a point where it's affecting other systems, you know, they all work hand in hand. You know, you have multi-system failure, right? Your this can shut down.
Carla, you still there? I'm sorry, it cut off.
Yeah, you hung up on me.
No, I didn't hang up on you. I just said it cut off. That's why I'm calling you back. What you mean? Go ahead, finish.
Yeah, because what was I saying? So the last question that I have for you as well. Now, would you agree? Can you guys hear me?
Yes, we hear you.
Okay. So would you agree that before it gets to this pneumonia stage, are you familiar that you're able to try to see? Because a lot of people are saying that you can actually treat it with like heat and linen and steam and through the nasal area. And I want to kind of point that out before it gets to this stage, because a lot of people don't know that it starts off as a viral and then it goes into a bacterial stage. Are you familiar with that as well?
No, I haven't heard of that change until you just educated me on that, sister. But what I will say is, I told you, you know, there are some things that we can do to kind of prevent it from getting in the lungs. Like I think that's what you're asking, nasally, because you know the nasal conchi is what catch most of the bacteria that we breathe and viruses we breathe every day, right? It catches.
Right.
There are some. Last time I was on here and I was talking about some nasal swabs that have a little alcohol on it that people, I heard some responses would just shot me down for that. But there's actually product out there called Nosin, Nosin, that is a nasal swab of alcohol that we use as therapists and healthcare workers. Sometimes we would do that before we even got into the hospital, because that will kind of and kill the disease before it gets down into the lungs. So I think as we're learning, sister, you know, learning new stuff every day about the kinetics of the disease. And so it's we're learning every day. But I would say prevent, wash your hands. If you get that nosing, keep you and your family's nose swabbed, you know, and do that. I've even got some things I want to put out there that I think will help. Okay. But I haven't had that opportunity yet. But, you know, there's some things that we do that have already been FDA approved before anybody said, oh, he crazy, right? It's already been FDA approved. We've already done it, okay? And I think if we start to utilize this treatment for preventive, right? We can either kill it faster or prevent it altogether. And so I'm just waiting on the opportunity to be able to get that out there as well.
All right. Thank you, sister. Appreciate that, Carla.
Thank you for the question,
Yeah. Thank you.
All right, this the sister Carla that will be Saturday going up against the sister that is getting ready to get on the phone now. So this is going to be
Peace and Black Power.
Peace and Black Power. Sister Nandi in the building. Sister Carla, y'all call back to back with each other. What's going on? How you doing, Nandi? What's happening? You got a question?
I'm good. I want to first thank the Dr. Ahmed Ra, for coming on and giving us this information, because I learned a lot today about the respiratory system.
Mm-hmm.
I did not know a lot of these things, and I want to ask you a question. If you can give us some type of input or solutions, maybe suggestions on what can we do, you know, if we happen to deal with people, like we come in contact with a lot of homeless people and stuff that have these issues. So if we can't get to a respirator or something like that with people that have these viruses or respiratory issues, what are some of the things that we can kind of do to, one, protect the respiratory system from viruses and respiratory issues, and something to help contain it if we're helping people out in the field? And that's just that's all I wanted to ask. But thank you so much, sir, because I'm taking notes. Thank you.
Oh, thank you,
sister.
sister.
I'll wait and listen to the answer.
All right.
All right. Yes, some things.
Thank you, sir.
Some things we can do right now. A lot of these, and first, let me say, I that's my aspiration, but I'm not a doctor. I am a respiratory therapist. I have a bachelor's in respiratory therapy, a registered respiratory therapist. I don't want nobody to say, oh, he ain't even no doctor. I'm not a doctor. I'm a respiratory therapist. But thank you for that, for your aspirations on my life, because I'm pushing for that as well. Second, I would say, yes, there's some things we can do. Like I said, there's nasal swabs we can do, which is the first line of defense to any foreign parasite, right? But for like the nursing homes, it's more of a protecting them from you, right? So we have to write the correct mask. We have so many people who are using masks that are not the correct mask. We see in the gas stations are selling masks now. I don't know if y'all seen that. But when I look at some of those masks, I'm like, you know, who made that, right? But the main thing we can do is try to protect your customer, right? If you're working in a nursing home, you're mainly trying to protect them from you, right? Not necessarily you from them. And if you have an opportunity, you need to be wearing, you and the patient need to be wearing N95 masks, right? Until this is over. Every patient in that hospital and every staff member, I'm not in the hospital, but that nursing home, and every staff member should be wearing N95 masks, especially in a nursing home. Now, out in the street, you can get away with one of those yellow surgical masks or one of those little light blue surgical masks. You probably can get away with, and let me see, matter of fact, I might have one in my bag. You can get away with, here we go. You can get away with that in the street. But when you're dealing with our elder brothers and sisters who are at a higher risk of catching the disease and dying because it's harder for them to get off the ventilator, right? And you have older lungs, which you can do more damage to their lung as opposed to a 20-year-old's lungs, right? So this is an N95 mask here. This is the N95. Okay, it even says N95 on it. Made by 3M. This is hospital grade. Got my little name on it. This is an N95, and this is also an N95. This one's called a duck bill, right? This is the duck bill N95 mask, right? These have been designed to protect you from any airborne illness, okay? Whether it's tuberculosis, whether it's pneumocystis carinii from AIDS patients, or COVID-19, COVID-20, 21, whatever they come out with. This N95 is designed to protect you, all right? Now, if you can get these into your facility and make sure your patients have these as well as you, right? Because if you can protect, if the N95 can protect the patient from you, then it can protect you from the patient, right? My mother said something that made me think the other day. She was like, I don't understand why we, if the yellow mask is not all right, if it's protecting people from me, then it should be protecting me from them, right? And I'm like, nah, mama, it sounds good, but you got to have the N95 because the particle size, that's the number one thing. The particle size of the disease is such a smaller particle that it goes through those yellow masks, right? Now, yes, the yellow mask will help you cough. Like if you cough, it catches some of your droplets, but it doesn't catch your aerosolized particles. And right now it is understood that COVID-19 is a droplet isolation, right? In a hospital or in your facility, they should be the universal. You have universal precautions, which is gloves and gown, right? Just gloves. That's universal PPE, right? But then you have contact isolation, which you have to wear a gloves and a gown, okay? Because if you contact a surface that has it, you can get it, right? But then they have droplet precaution, which is in green, right? That signage is green, called droplet precaution. That means you cannot be within 3 feet of somebody's sneeze, right? If you are, you'll catch it, right? And then the number one isolation is airborne, okay? So having a N95 mask, right? Either the duck bill or the regular traditional one will protect you from all aerosolized particles. And as well, the room that the patient is in are negative pressure rooms. That means, if I shut the door on a negative pressure room, you say you have tuberculosis or something, you have an airborne disease, and I put you in a hospital room and I shut the door, I should be able to strike a match and put it at the bottom of your door and it blow it out, okay? It sucked my match to where it's out. That means the air inside of the room is being sucked out of the ceiling, okay? Because it's catching any aerosolized particle that you may have, or me, since I don't have I might not have the symptoms, but could still have COVID. If I do talk or cough, it sucks it right out of the building, okay? So for the answer to the sister's question, try your best to protect your nose, wear N95 mask, and if you can, move your patients to negative pressure rooms.
Peace. Let me ask you this. See, I made a mistake. I didn't order it, but my children ordered it online and they got the KN95. This is not even the one though, right?
I think if it says N95, I don't think they can fraudulently sell it and say 90. If it say N95, it's good.
Yeah, because, I ordered 100 of them. So basically they was telling me that the K just mean it came from China or something like that.
I think it's called Kanache. I forgot what.
Oh, okay.
I forgot what the name was, but like the one I have is hospital grade.
Yeah, that's the one. Yeah, that's the one I was trying to get, but
they ended up giving me healthcare grade. But yours is the same as mine, Si. It's just a different color. If it says N95, it protects the same size of particles.
Okay.
You can get them at Home Depot. N95 Home Depot. You know what I'm saying?
Okay. Yes. Peace and Black Power family. What's your name? Where you calling from? Peace. What's your name? Where you calling from?
Yeah, I'm Cedric. I'm Cedric calling from New Orleans.
What's going on, Cedric?
Oh, New Orleans.
Okay. Yeah, sure. I know it, man. We putting the bad rep out there right now with this COVID-19. Mm-hmm. I want to ask a question though. Does it go on the human's immune system, or is there like a time frame for a virus to actually, like, I guess, evaporate or disappear, or does it just stay in society as long as we get immune to it, we just don't get affected, or some people get affected a second time? How does that actually work?
I think it's more like antibodies. When any kind of foreign disease come into the body, the blood's ears pop up, right? And the blood starts to form antibodies, right, to fight that particular disease, okay? And sometimes the disease overpowers and kills a person, or they can survive. I don't know what the time limit is. I think it depends on the person, right? But what happens is over time, the body will build up enough antibodies to kill off the virus. And once it's dead, your symptoms go away, right? Our symptoms are just reactive of the virus, right? Or the disease, whatever it is, like can't breathe, fever, all those type of things. And so the body heats up because viruses and bacteria don't like heat. And so the body will heat up in fever to kill off the virus, right? So we have to, and that's another thing, you got to be careful with hitting Tylenol and Motrin just back to back, because you're killing off the fever, right? The fever is what helps kill the disease, right? But after a while, I don't know the time frame, brother, and I'll look into it. And if somebody else knows, they can tell us. But it depends on the antibodies. Your body builds those antibodies. It starts to fight. It's a war, right? And then when hopefully the body will overcome the disease, the virus, the bacteria, whatever it is, and then you will have those antibodies in your system. So if the body happens to see it again later, it'll already kill it, right? It will kill it right off the rip because it's, oh no, not you again. I got you, right? The body usually, that's the response the body will have the second time around. But the time frame, I'm not sure.
Does our body get a better inclination inside, or you think we'll be a better inclination to heal itself outside?
Say that again, brother.
You think our body will have a better inclination to heal itself, to develop those bodies inside of the home or outside of the home?
Oh, the antibodies only form when you get exposed to it. So wherever you get exposed to it, that's when it starts to make antibodies. Your body's not going to make antibodies unless the COVID or whatever it is gets into your body. Once it gets into your system, it notices, hey, what is this, right? What is this bacteria? What is this virus, right? And they go to war. And once they go to war, they make antibodies to always watch out for you again, right? So it just depends on where you come from.
Okay.
Mm-hmm.
Okay. Yeah, man, I appreciate that. Hey, on another note, bro. I definitely want to invest into you, Saneter. Are you talking, or you want to get the
Say that again?
Yeah, I definitely want to invest into you, man.
Okay.
Definitely into I've been watching for about 10 years now, bro. I'm actually in a position to invest now, and I definitely want to, stick it in with the black people, man. I was I'm on the Claude Anderson and I can't never remember you, man. But
all right, brother. I'm writing your number down. I'll give you a call.
Definitely do that, man. Definitely do that.
All right, be safe down there, brother.
Yeah, man. Peace. I appreciate it.
Peace, brother.
All right. Yeah.
All right. For the last time, Garfield is family. Garfield is House of Consciousness. Garfield is my brother. Why are y'all banging on my brother in the House of Consciousness? I mean, come on, man. Y'all got to stop the nonsense, man. Please. I'm asking y'all for the last time, man. I'm trying to show everybody the love. But y'all can't do that. You can't do that, man, for real. Garfield will protect me in his chat, and I got to return the favor. It's the same way over here, man. So don't get it confused, y'all. Please don't get it confused.
Dude, I'm on the phone. Go.
All right. Peace and Black Power family. What's your name? Where you calling from? All right. Peace and Black Power family. What's your name? Where you calling from?
Hey, it's Brother Garfield. I just want to say great show today, Saneter. You're showing why you are the king of information. The brother came on. I want to say, brother, I thank you for taking out your time to come on Saneter today. I know you're a busy man. You're taking time from your family, your kids. I want to say thank you, first of all, for your service. That's what I want to say. All right.
You don't have a question, Garfield?
Yeah, I wanted to say to the brother, would you agree that, what was the word I said? What I said to you yesterday, septic shock, which is what you explained about the breathing. Would you agree that the people that are put on ventilators, from what you know, is because of them having lack of oxygen going towards their lungs? So the only way in that situation is not about doing a therapy at your house and you got your little person that deals with that type of stuff like a Queen of Four or whatever. It's not like you have a on-call Queen of Four, you know what I'm saying, next door to come and massage you and get your lungs right. So would you agree that the ventilator is given as an option, final option, because the person can't get the oxygen to their lungs? Would you agree?
Yes, I would say this. If I filled up this room that I'm in right now with just, oxygen only goes to 100%, but just say I was able to fill this room up with 500% oxygen, right? If I don't take a breath, the oxygen is no benefit to me, right? I have to be able to ventilate in order to use the oxygen. And so when people get to the point where they can't breathe, I don't care how much oxygen is around them or how much I'm trying to throw at them, I have to push it into their lungs. So yes, if it comes to the point where you can no longer ventilate, then you can't oxygenate, right? Ventilation is first, oxygenation is second, because it don't matter how much oxygen is around you. If you don't suck it in, what's it gonna do, right? It can't do nothing for you. So yes, we got to, you know, when a patient gets sick enough to where they cannot ventilate, we have to do it for them. And not only do we push volume in them to keep their CO2 levels and their pH right, we're also keeping their oxygenation status where it should. Because if your oxygenation is the problem, it's called hypoxic failure, right? They die of hypoxemia, right? Which is a lack of oxygen in the blood. Or you can die from respiratory failure because you didn't blow off enough CO2. So you got to do both, right? When we're putting someone on the ventilator, we are delivering both, okay? We're managing both. And so, yes, you got to ventilate in order to oxygenate.
Yeah, I would say one of the things I learned about this was over 10 years ago. My sister died, I think, 14 years ago. And what happened is she couldn't breathe. She had cancer. And so she came to the point where she couldn't breathe. So they put something on her face to blow the oxygen to her lungs because she couldn't get any oxygen. And then they had to sedate her to get her on the machine or whatever. But I'm saying this because I know they decided to ventilate her because that was the last option. So when people hear about ventilator stories, I'm speaking from experience. That's the final option. So I don't think the people are giving them that to kill them per se. I think where that killing stuff comes from, I might be wrong. This is not fact. There's a story that came out in the New York Post of how they're prioritizing who gets the machine. So the older folks wouldn't get it. The ones that are like over 80 and very sickly, they wouldn't get the machine. They would give the younger people. And that's probably where the rumors are, where that got out in New York, that they're letting the people die. So I'm not saying the story is completely a lie, but that they were prioritizing and saying the people who are sickly, like the ones in the nursing home, they wouldn't get priority over somebody who's like 31 or 26, who's pretty much healthy, but that would probably keep them alive. So that's probably Saneter where all of that actually comes from. So it's not that the lady is completely lying, but the story coming down the line might be grossly exaggerated. That's what I think. I don't know if Saneter gonna agree, but Saneter.
No, I hear what you're saying, brother.
Well, we did have such a shortage of ventilators, right? The New York's Cuomo was scrambling trying to get ventilators, and so when you have a short amount, I'm sure I wouldn't doubt that they would say, okay, well, it's just kind of like on a boat. If your ship is going down, who go out first? Women. Right. So they start prioritizing, because we ain't got enough boats now, so everybody ain't gonna, but we're gonna make sure we get the women and the children off, and then everybody else. But I can see that, brother, because somebody who is really, really old, they probably consider, hey, they've lived a long life. If they do this machine, they may not be able to get off. And we have some people who are maybe in their 40s or 50s that may be able to be more beneficial to them because they will have a better chance of getting off, right? And then have 1,000 and we got 10,000 people who need them, right? So I can see that being an issue.
Yeah, my son, he's here. He has what's been tested positive. So now we kind of let him come back in now because it's been over 14 days since he was diagnosed. And he's been shown no symptoms since the positive test, and he's doing pretty good, but we still practicing universal precaution because you never know, you know what I'm saying? So that's me for the rest of my life anyway. I'm just going to practice universal precaution. Man,
my sister died of lung cancer too, man. Well, she had thyroid down to the lungs. She was on a ventilator, all those things. I mean, I understand totally.
The craziest thing, my sister told me not to resuscitate her, right? And I was trying to let them resuscitate her. People said, no, don't resuscitate me. I'm like, nah, man, I ain't doing that.
Yeah.
But anyway, peace and love, family. And enjoy the rest of the day. Good show.
Peace, Garfield. Good looking.
When is Ali Muhammad coming on? Tonight?
Tonight at 6. Continue to watch, Garfield. I want to show you something. Keep watching.
All right, cool. Yes, all right. Sir.
All right, my brother. I'm going to allow you to close out right quick.
All right.
All right.
I said, I'm not getting paid.
Press 1 to send a voicemail. Press 2.
Ventilators, nothing like that. I am simply trying to give you the pros and the cons to adding positive pressure into the system. It can have some negative effects, especially for those who may have already compromised systems, right? If your lungs are already diseased or your heart is already diseased, it can cause more, some problems that you may not get off. It's possible. But the bottom line is, when you can no longer take a breath, right, you will have to have some positive pressure added, whether it's a mask or a tube at some point. And if you don't have it, you will not make it. All right. That's only when you get to the point where you have to have it. I'm not saying everybody's going to need the ventilator, but when people get to that point, it's necessary. Okay. And I just want you to weigh those options before you sign a paper saying, don't put my mom on no ventilator. Don't put me on no ventilator. Don't do it because you say, oh, ventilators are killing people. It's more intricate than that. All right. It's more intricate than that. Just be mindful when you make those life decisions, because when you make that decision, it's going to get wished. The wish is going to get granted. If you say, I don't want to be ventilated, you won't be ventilated. And that could be detrimental and something that could have saved you. All right. And so with that, be safe, swab your nose. Don't forget nosing, N-O-S-I-N. I don't have stock in the company, nothing like that. I just want you guys to be safe. Get the right kind of mask, wash your hands, and be safe.
Thank you, my brother.
All right.
Peace. Appreciate you. Great job. All right, family. So in closing, I ain't gonna go crazy because I don't want to mess up the show. But Jeremiah Judah got emotional, he got hot, he got heated at me because I told him to stop banging in the chat, stop going at Brother Garfield. So he sends me a long text. He sends me all of this long text. And he said what I already knew. He said, man, that B nigga got the dude that said boycott you, Saneter, on his show, meaning you, Garfield. I already saw that. So I was like, I can't tell nobody who to bring on this show. But I did look at that and I'm like, damn, why would he bring that dude when he was trying to boycott me on my show? So I did say that. I ain't gonna front. I was saying that before Jeremiah seen it. But he went on to go and to say that I'm gonna build my own it while them same niggas smile in your face and backstab you. You keep your wrench, and tomorrow he gonna be talking it about you. F you, meaning me. He said F me and Garfield. Jeremiah, F me because I said stop arguing with the brother Garfield? So you got mad at me and said F me and Garfield? Come on, Jeremiah. Come on, brother. Be real with that. But see, this is again, these are the people who claim to have a close connection to their almighty, powerful God. These are the brothers that step up and act just like the nigga on the corner. The niggas on the corner. What makes them better than them brothers that's on the corner selling weed and stuff like that? But these supposed to be men of God. You see what I'm saying? This is why I don't respect them. This is why I got mad love for ISUPK, Captain Tazoriak, and a team, because of their discipline. You see what I'm saying? It's because of their discipline. This is why I got mad love for Daniel Allah and a team, because of their discipline. But these dudes, these renegade wannabes, Hebrew Israelites, don't know how to act. They don't got no discipline. They don't got nobody to look up to them to tell them when they right or when they wrong. You understand what I'm saying? But when you are in a movement like ISUPK, like Lions of Israel, you gotta be disciplined and you can't make moves on your own. This is why Captain Tazoriak always say, when I ask him to come on, he say, brother, I gotta go and check with my generals first. And at first I was like, come on, man. But then I understood it because I was in the movement with Dr. Khalid Muhammad. Before I could do anything, I had to go and check with my higher up first. You see? So these dudes don't have nobody to look up to. They are wannabes. They wannabes. They not no real Hebrews. They want to be that. This is why they can say what they want to say and do what they want to do, and they don't reap no repercussions behind that. So all in love that y'all see me give Brother Jeremiah Judah, he ended up saying, cursing me out, F you and Garfield, because I don't want him banging on Garfield in my chat. And this is crazy, family. So I took his wrench, and of course I took Carla's wrench because that's his girl. That's his queen. And so I don't think she will be debating Sister Nandy, because that's what he's going to do. Yo, stay off of there. Don't go over there. And you know they are like this. It's whatever the man tell them to do. They don't have their own goddamn brain. You already know. If you take their brain out of them, I mean, man, listen. If you put their brain in a bird, the bird will fly backwards. That's the type of people that we be dealing with sometimes. Oh, my bad, Daniela. Yeah, I should have been hit you with that. But yeah, man, this is why I have the love and respect for these groups. This is why you see, yeah, I had a fallout with my brother one time, but that's what family do, and you get it back together. But this is why I got mad love for the captain and ISUPK and mad love for my brother Daniel Allah, because they don't behave like this. They don't behave like that. You feel me? You don't see that type of stuff going on. And so you already know, Carla's not going to be, and that's cool. I'm glad. I don't care. I don't want nobody that's controlled anyway, right? So I don't give a damn. Go build your platform, brother, if that's what you want to do. So we ended it on that note. Great show, brother Amin Ra, and be looking forward to having a part 2. Peace and Black Power. We out of here.